My name is Lars Hallström. I'm very pleased to welcome you all today to this lunchtime presentation from Dr. Adesola Odole, coming to us all the way from Ibadan University in Nigeria. I'm just going to say a few very quick words of welcome to everybody and begin with a territorial acknowledgement of our First Nations people. Okay, and welcome. And we acknowledge, of course, all First Nations and Indigenous peoples and all peoples to our territories. Here, I'm not in Lethbridge. I'm currently in Camrose, so I'm in Treaty 6 territory. Jeff and the Prentice Institute are located in Treaty 7 territory. And again, welcome and thank you for coming. A few quick comments. I am the new director of the Prentice Institute, so this is a first on a number of fronts. This is the first webinar that the Prentice Institute has hosted, which explains, of course, but doesn't excuse some of the technical challenges. This is also my first event as director. I came on board in January just of this year. And of course, I'm very pleased to see that we have an international speaker joining us today because, as you know, the Prentice Institute has a mandate that is global and not limited to Canada or Alberta. So just a few quick notes. We do have another presenter coming up in March. Dr. Constantine Posadas from the University of New Brunswick will be speaking on March 19th, and details for that are available on the website. We also have recently released a call for Prentice affiliates, so for new affiliates, as well as a number of funding opportunities for the University of Lethbridge faculty, ideally conducted in collaboration with other faculty members, both at the university and elsewhere. These include the research affiliate funding stream, as well as the seed grant stream, and again, information for those is available online. So we encourage you to take a look at those. If you have not already applied for or hold them, we encourage people to pursue these opportunities. So a few quick words for our speaker today. And again, welcome to everybody. Dr. Adesola Odole is an associate professor in the Department of Physiotherapy in the Faculty of Clinical Sciences in the College of Medicine at the University of Ibadan, Nigeria. That's a very long collection of words to fit on a business card. She is a specialist advisor and honorary consultant in orthopedic physiotherapy at the University College Hospital, again in Ibadan, and she obtained her Ph.D. in orthopedic physiotherapy from the University of Ibadan as well. She serves as an assistant coordinator of biomedical education in the program there, College of Medicine, and is also chair of the Scientific Council of the Association of Clinical and Academic Physiotherapists of Nigeria. So with that, I will turn this over to our esteemed speaker. She's going to talk for approximately 45-50 minutes, and I'll ask you to submit questions via the chat function, which is the purpose of the webinar, and then we'll have time for questions and discussion and response at the end. And so welcome everybody, and Dr. Dole, welcome, and the floor is yours. Thank you so much.
Thank you so much. Thank you. I'm happy to be here. I know is good afternoon to you all in Canada. Here in Nigeria, it's a few minutes past 8 in the night. So I'm actually very excited to be the first presenter of the Prentice Brown Bag Talks for the year 2021. And not just that, this is the first virtual Prentice Brown Bag Talk. So I think I'm actually very honored. I want to thank the Prentice Institute for Global Population and Economy for giving me this platform to make my presentation today. Like it was introduced, the title of my presentation is Cultural Conflicts in the Paradigm Shift from Healthcare Provider-Centered Care to Patient-Centered Care in the Care of the Elderly. I bring you greetings from the College of Medicine, University of Ibadan, Nigeria. I have an outline for my presentation. I'll be setting the scene by sharing with you my experience with one of my patients. I'll be talking about aging population and outcomes of care, healthcare provider-centric care, patient-centric care, cultural conflict in the care of the elderly. Then I'll be looking at possibilities to explore in order to resolve this cultural conflict. Well, I know that over there in Canada, when you talk about older adults or when you talk about the elderly individuals, the word seniors come to mind in Canada. So I just want to ask a question, and not just one question. I'll be posing some questions for as many of you that have cared for an elderly person before, or maybe you have an elderly person in your neighborhood, or in whatever capacity, if you have an elderly person around you. So I'll be asking a few questions. If it were to be a physical meeting, I would have asked us to respond by show of hands, and I would have heard your responses. But as it is, it's a virtual meeting, so you can type your responses in the chat box. I will get to read them after my presentation. So the first question I'll be posing is, have you cared for an elderly or a senior before, whether in the capacity of a healthcare provider or an informal carer or a formal carer? What exactly did you focus on? If your answer to my first question is yes, how did you arrive at what you focused on in the care of the elderly? What was the most important thing to the elderly? Did you bother to ask the elderly or the senior about what was most important to them? Okay, this is supposed to be a Prentice brown bag talk, and I guess it's lunch hour there for you in Canada. So I expect that you have your brown bag handy. I don't know exactly what you have in your brown bag. It could be a piece of cake. It could be snacks, meat pie, biscuits, or you have an apple, a bottle of water, a bottle of juice, or whatever kind of drink. I want to enjoin you to sit down, relax, and enjoy this talk. Majorly, the objective of my talk this afternoon in Canada and the night here in Nigeria is to bring to the fore cultural conflicts in the care of the elderly in Nigeria as compared to that of developed nations, which Canada actually belongs to. Specifically, I would be identifying the paradigm of care for the elderly in Nigeria. I'll give some highlights on the global shift in this paradigm and identify the cultural conflicts in the care of the elderly. Okay, now, I said when I was trying to give you an outline, I said I'll be setting the scene by sharing my experience with the patient. So now it is story time. Here in Nigeria, when the storyteller says story, those who are listening to the storyteller would say story. So now that it's story time, I would want you to just respond wherever you are. I might not be able to hear you because of virtual meeting. So I'm saying story time, story. So I expect you to say story. So I'm going to be telling you a story about one of my patients. It is actually a true life story. It is not a fiction. A true life story of a patient that I managed about 15 years ago while I was a clinical physiotherapist at the University College Hospital, Ibadan, Nigeria. This patient, I've decided to give him a fictitious name just to protect his anonymity. So I've decided to call him Mr. Ladigi. So the story I'll be talking about this afternoon is tagged Mr. Ladigi's story. Mr. Ladigi then, about 15 years ago, was a 64-year-old man that presented to the outpatient clinic, of the physiotherapy department in that hospital. And he was referred on a diagnosis of osteoarthritis of the right hip and the right knee. And I'm looking through the radiographs of the patient, normally when a patient comes into the clinic, and considering the fact that by the time that patient got to the clinic, I had about 16 years of clinical experience, and I was so proud of myself, so to speak, that this particular patient is a patient that I can manage very well, because I had managed several patients that had osteoarthritis of the knee, basically looking at my pattern recognition, clinical reasoning skills. So I identified all the symptoms that Mr. Ladigi had. I also elicited some signs, based on Mr. Ladigi's presentation. And to the best of my ability, I managed Mr. Ladigi attending to all of those things that I thought were very, very important to him, in my own opinion. I managed his pain. He had pain at the right hip, pain at the right knee. He had limitations in the range of motion at the hip and at the knee. He had muscle weakness of the muscles of the anterior and posterior aspect of the knee. He also had difficulty, a kind of walking functional limitation. Just a minute, let me just start my video now. I don't know if you can see me now. Okay, so as I was saying, he had a limitation in walking function. And those were the things that I thought were very, very important. I set my goals. I made decisions on the best intervention for Mr. Ladigi. I'm going to pause a little bit now because I don't want to tell you the full story at the start of my presentation. I'll be interspersing the story of Mr. Ladigi with my presentation. So if we were to look at the age of Mr. Ladigi, 64-year-old, I'm sure you agree with me that he falls into the category of older persons. And looking at what we have there, if you look at all the regions there, we have the North American region, we have the North American region, we have the Central America, we have the South American region, we have the African region, we have Europe, we have Asia, we have the Oceania. And if you look at the colors of the regions, looking at the slide, all those regions that had the dark colored blue had percentage of older adults aged 60 years and above when we project to the year 2050. If you look at the African region, it looks like the color is gray. That is, they have less than 10% of older adults, okay, progressing as the years go by. So by 2050, if you look at it, the North American already has the dark shaded parts. That is what we have there. That is to tell us that populations are getting older all over the regions, across all the continents, globally. And according to the United Nations Department of Economic and Social Affairs Population Division, globally, the proportion of older persons aged 60 years and above make up 12.3% of the population. And that is actually alarming. And they also reported that by 2050, that proportion will rise to almost 22%. So we have an aging population at hand. Okay? If we're looking at that, the previous slide again, what we have in Nigeria is like Nigeria has the sub-Saharan Africa rather has the smallest proportion of elderly and aging slower than the developed regions. Even at that, it has been projected by the United Nations Department of Economic and Social Affairs Population Division that by between 2000 and 2030, that population will grow by almost 2.5 in size. If you look at that, the bar charts, looking at the bar charts, okay, there is a rise in the proportion of elderly individuals, even in Nigeria. By the year 2050, we're going to have 20 million of the Nigerian population falling into the category of older adults. So it is important that we consider this group of individuals who are within the vulnerable population. Even in Canada, Canada's population is also aging. It is aging such that the proportion of seniors in the Canadian population will rise from 16.9% to 21% over the next 10 years. That is actually a huge concern too. And then over the next 20 years, it's going to grow by 68%. And if you look at all of the states in Canada, virtually all of these states will grow by twice the size and the proportion of elderly individuals. So it is important. This information I obtained it from the Canadian Institute for Health Information. So the aging population cuts across all regions. Canada, using Canada as a developed nation and looking at Nigeria as a developing nation. Okay, so with the background information of this aging population, I guess that every one of you would agree with me that these older people, they stand at high risk of being separated from families. They could have physical disabilities. They could be cut from services. And again, majority of these elder adults could suffer physical and psychological distress. They could have specific health and nutritional needs considering their population, their age group. And of course, they could stand the risk of abuse and neglect, especially when you look at older women. And because of all this anonymity of the challenges and the risk that they stand to have, it is important that globally, every population, every region should set in motion the right set of policies that would help to equip the society to address all of these challenges. So now let's get back to that, my story. Okay. So I had managed Mr. Lagidi for close to 20. I'd managed him for about 3 months, and I had over 20 treatment sessions. I thought I had given him my best. I had given him my best as an experienced physiotherapist, so to speak, at that time. But I didn't know that there was something that was bothering Mr. Ladigi that I did not give consideration to. I didn't know. I thought I had managed him. I had assessed his muscle strength, assessed his range of motion, I had assessed his pain, assessed his working function, I had assessed the atrophied muscles, I'd helped him in building up the atrophy of the muscles. But there was something that Mr. Lagidi wanted me to do that I didn't ask for or I didn't probe into. So we just continue again we'll continue later about this story. I will intersperse this talk with the story of Mr. Ladigi. So if you were to consider all of those things that I focused on, I told you that I focused on his pain as an elderly person. Pain was the major symptom that brought him to the physiotherapy clinic. So I focused on his pain, his muscle strength, his muscle girth and atrophy, the joint range of motion, the balance. I didn't focus on balance then. I didn't even think about balance. But of course, balance is very, very important as an outcome in the care of the older adults or the senior. I focused on his working function. All of those things that I focused on can be termed as healthcare provider-centric outcomes. They were outcomes that were meaningful to me as a physiotherapist. And I want to crave your indulgence to permit me to talk about, when I talk about healthcare provider or healthcare professional, I'll be referring to my discipline as a physiotherapist because that is my domain. So those were the things I focused on in the care of Mr. Lagidi. And those are the things that it appears that majority of healthcare professionals actually focus on. And those outcomes are termed healthcare provider-centric outcomes of care. Now, looking at that particular outcomes of care that I focused on, it is actually a kind of paradigm here in Nigeria. It appears that most of the healthcare professionals in Nigeria focus on such outcomes. And that model of care is termed as the biomedical model of care, because all of those outcomes that I focused on were outcomes at the level of the cellular level, the tissue, the level of the tissue, and the level of the organ. They are termed as impairment outcomes. But, literature has shown that in outcomes assessment, that when we talk about outcomes assessment, that it provides the mechanism by which the healthcare provider, the patient, the public, and the third-party players of health are able to assess the end results of care and its effect upon the health of the patient and the society. But unfortunately, while I was trying to manage Mr. Ladigi, I didn't focus on, I didn't focus on outcomes that were important to Mr. Lagidi. Not because I chose not to, but because I didn't know that I had to focus on outcomes that are meaningful to Mr. Lagidi. And when we talk about this biomedical model of care, we often focus on red flags. Red flags are clinical indicators. They are clinical indicators of possible serious spinal pathology. There could also be physical risk factors of significant medical pathology. So basically, in the biomedical model of care, I was focusing on the etiology. It's etiology focused. It's based on the etiology. I was trying to look at the pathology. Okay, the patient has pain. Oh, he has this. I didn't focus on things that bothers on the patient. And what that means, or what that translates to, is that the patient's voice, particularly that of the elderly, is often neglected in clinical decision making. I made a lot of clinical decisions about Mr. Lagidi, decisions about his diagnosis, in setting goals, the decision about his physiotherapy intervention. But I didn't involve him in all of this decision. And that is the paradigm of care that we have in Nigeria. So now, globally, evidence has shown that there is a need for healthcare professionals or healthcare providers to shift from this paradigm of the biomedical model of care. The biomedical model of care focuses on illness. It focuses on pain, disability, the pathology, the etiology. There is a strong advocacy that we should move from this biomedical model of care to a model of care that is concerned not just about the illness of the patient, but concerned about the wellness. And when we talk about the wellness of the patient, that is the biopsychosocial model. It is something that is all-encompassing. It talks about the thoughts of the patient. It is a kind of model that sees the patient in a holistic manner. Talking about the patient and self-efficacy. Do patients have confidence in themselves? Do they have the resilience to go through whatever therapy that is being given to them? What are their behaviors? What are those things that matters to them? What are those activities that they hold dear to heart? What exactly is their connectedness in terms of their participation in the society, societal role? All of these things are very important, and that is where the shift comes in. Patients should not just be seen as somebody that is in disease. Individuals that have one ailment or one disorder or the other should not be seen as just people that are ill. We should move from seeing them as individuals that are ill to those individuals that can actually achieve wellness. And that is where the biopsychosocial model of care actually comes in. So now, if we begin to look at the biopsychosocial models, what exactly does it mean? It means that the patients are seen as partners in their care. You know, when you have different kinds of healthcare providers in a multidisciplinary kind of setting, the patient is the most important person. If I were to regard the patient as a commodity, I would say that the patient is the most important commodity of life. So if we have to take care of our patients, we should consider their opinions and their views. And then some researchers have reported that healthcare providers increasingly recognize the need for patients to participate in decision-making. That is actually very important because when they participate in decision-making process, their priorities and values are being considered. Again, Hills and Kitchen 2007 also reported that eliciting and incorporating the patient's expectation. When we incorporate the patient's expectations with the needs of care, there is a very high contribution of this to a more favorable perception of the whole therapeutic experience. So, in the biopsychosocial model of care, patients are not just people in disease, they are partners, in clinical decision making. So, that leads me to talk about the patient-centric outcomes. I talked about the healthcare provider-centric outcome, that is outcomes that are meaningful to the healthcare providers. Okay, now let's look at outcomes that are meaningful to the patient. Okay, we have self-efficacy. If you must have an effective, treatment outcomes, patient-centric outcomes will be considered. The self-efficacy of the patients. Do the patients have any form of mild to moderate depression? Do they have depressive symptoms? What about the patient's perception of the illness? How do patients perceive that particular disease or disorder? Here in Nigeria, we have patients that perceive diseases as being a cause. They perceive diseases as being not out of natural consequences of diseases. They perceive illnesses and diseases to be from maybe a supernatural force, okay, that is angry with them. We should also consider anxiety, especially in the older adults. Remember that I talked about some of the risks that they stand to face. Risk of being separated from families, okay? And elderly individuals that have had a previous fall will definitely have the fear of falls. And again, they could have adesophobia. And when we talk about adesophobia, we are talking about an excessive, okay, and debilitating fear of physical movement. You know, they just have that debilitating fear of physical movement. They don't want anything, they don't want to go through any form of exercise because they have this feeling of vulnerability, of a painful injury or injury. Again, pain catastrophizing. When the patient has this tendency to magnify the threat value of pain, they have the tendency to describe their pain experience in more exaggerated terms. If we don't handle such outcomes, we will not get very favorable therapeutic experience. Sexual functioning. Many people seem to feel that for elderly individuals, their sexual life should not be given consideration. This is not true. It is not true. It is a patient-centered kind of outcome that everybody that takes care of the elderly should give recognition to, give cognizance to. Sexual health-related domain of the quality of life should be given consideration. Do we even bother to check the outcomes of our patients' satisfaction with care? This is very, very important. All of these outcomes that I've listed are not they're inexhaustible, but I've just been able to mention a few for the purpose of this presentation. So if we consider the WHO international classification of functioning, disability, and health, this classification system actually addresses human functioning. It provides a kind of a standard, a uniform language or framework that describes how people with a health condition in a kind of a positive term, not just talking about disorder or disease, you know, how they function in that health condition, how they function in the normal activities of daily life. The ICF does not put emphasis on a label diagnosis or in the presence or absence of a disease. It provides emphasis on functioning of the patient, okay, functioning and their disability. It actually has two domains, functioning and disability, and the contextual factors. So if we look at the positive aspect of the health condition, we just call it health condition. But when you talk about the negative impact of that of the disorder, we now begin to talk about the disease that the patient has. So at the level of the body functions and structure, if a patient has problems at this particular level, we talk about the impairment. Remember, I talked about impairment outcomes in my management of Mr. Lagidi. So problems at the level of the tissue, the cellular level, at the organ level, at the structural level, body functions are referred to as impairment. And an activity is the ability of an individual to execute a task or action. So if the impact of the disease or the disorder limits that individual from performing or executing a task, we talk about activity limitation. And of course, the participation talks about involvement in life situation. So if there is any problem at that level of getting involved in life situation, we talk about participation restriction. So all of these things talks about the holistic management of the patient, giving consideration to the environmental factors and the personal factors of the patient. And in talking about the environmental factors of the patient, we talk about things that are not within the control of the individual. We talk about family, we talk about work, we talk about government agencies, policies, laws, cultural beliefs. All of these things together, embody or signify what the biopsychosocial model of care is all about. Personal factors of the patient, the age, the gender, the race, educational level, the coping styles of the patient, and the environmental factors, the personal factors are contextual factors. There are wide variability among cultures. For instance, in Nigeria, a person that does not have access to a public building because we don't have ramps at such public building will be limited. Whereas if you get to a place where there are ramps and the individual that is mobile on a wheelchair is able to use the ramps, that individual is not limited. Is not limited in that particular task. So all of these are contextual factors. So this ICF places an emphasis on the biopsychosocial model of care. In the biopsychosocial model of care, unlike the biomedical model of care where we give consideration to red flags, in the biopsychosocial model of care, we talk about all other types of flags. We talk about the yellow flag that borders on the emotional and behavioral factors of the individual. This is very, very important because an individual that has a low self-esteem, that has a low level of self-efficacy, or somebody that has anxiety and depressive symptoms, has a high tendency or a high likelihood of not yielding to whatever intervention that is being provided. Also, we should consider the blue flags that borders on the social and economic factors, the black flags that borders on occupational factors, the orange flags when you talk about psychiatric factors, when you talk about patients that are engaged in illicit drug abuse, patients that have issues with forensic issues, patients that have active psychiatric disorder, unlike those that have mild to moderate depressive symptoms. So all of these are psychosocial indicators that we must put emphasis on when we manage our patients, which we do not often lay emphasis on because in Nigeria we focus more. Anecdotally, it appears that we focus more on the biomedical model of care. Now, we are in the era of accountability and outcomes assessment. Everybody, there is no nation that is exempted from this era of accountability and outcomes assessment. And all healthcare providers are challenged to provide evidence of effectiveness of interventions in a way that it is meaningful to all stakeholders. And who are these stakeholders? Patients, healthcare provider, third-party payers of health, and the public. And the discussions all over the whole place about evidence-based practice is probably an extension of this era of accountability. But I didn't know so much at that point in time. There was a time when I was managing Mr. Lagidi, I didn't know about outcomes assessment. I didn't know that I had to provide evidence of my intervention, of effectiveness of my intervention in a way that is meaningful to Mr. Lagidi. I just did what I thought was best. And even at that point in time, I was being seen as somebody that manages a patient very, very well with an effective treatment outcome. I didn't know that I should consider what was important to Mr. Lagidi then. So if you look at the dimensions of evidence-based medicine, evidence-based practice, there is a particular dimension that focuses on the patient's preferences and values. It's not just about the clinician's training. I was trained as a physiotherapist in the management of Mr. Lagidi. I had experience, 16 years of experience cannot be sidelined, okay? But I didn't know that I was supposed to use the judicious integration of science. I was just doing what I thought was right and appropriate in the management of Mr. Lagidi. Evidence from developed nations and even developing nations have shown that the patient-centered kind of care is very, very important. The patient-centered kind of care, where you have the patient in the center of the management, is what is very, very important. What should be adopted by all. And in this patient-centered care, the mission and values of whoever the carer is, whether formal or informal carer, should be aligned with the patient goal. You should not just set goals out of the values of the patient. When I managed Mr. Lagidi, I set all the goals myself. I didn't involve him in the goal setting. The care must be collaborative, coordinated, and accessible. That is what we are talking about. That the physical comfort and emotional well-being of the patient should be seen as top priorities. And again, the patient and family's viewpoint. It is not just enough to look at your own viewpoint as the healthcare provider. The patient and family's viewpoints should be respected and valued. Whatever decision that the healthcare provider or the carer has to make, he or she must incorporate the patient and family in the decision making. That I didn't do because I didn't know I was supposed to do that. So there must be full transparency. Okay, there must be full transparency and fast delivery of information. We should provide our patients with information. They should be empowered to self-manage themselves, to be partners in the decision-making process. Well, I and some of my colleagues actually did a research on the agreement level between patients and physiotherapists' expectations of care in some selected Nigerian tertiary health institutions. And we found out from that research that almost 72% agreement level between what the patients expected and the physiotherapist's expectations. And some of the things that the patients agreed on, and they said from that particular study, where, number one, that the physiotherapist should understand the patient's feelings. The patient should be seen as an individual, somebody that has blood flowing in his vein. The patient, we should have empathy for our patients. That is exactly what the participants from that study brought to fore. That physiotherapists, healthcare providers generally, we should listen to everything the patient has to say. I know that sometimes, somehow, we could have a busy clinic. That is what happens. That is what plays out in Nigeria. You have a busy clinic and you need to attend to all of the patient. You don't have time to listen to the patient. Active listening. When we integrate active listening skills, it is very, very important to the patient. The participants also reported that the physiotherapist must understand how the illness affects the patient's life. Talking about the illness perception. How does it affect the patient's life? The physiotherapist should ask patients' opinion before making decisions. Unfortunately, I didn't ask Mr. Lagidi for his opinion before making decisions that I thought were most appropriate for him. Another research that I carried out with them in collaboration with some of my colleagues in Nigeria also reveals that patients that had high proportion of that exhibited kinesiophobia, that's fear of physical movement, they had the tendency of having their pain for a longer duration, that is more than 12 weeks. So their pain got into a chronic situation, the chronicity of their pain, just because they exhibited high level of kinesiophobia. These individuals, again, also had very high contributions to the increasing level of disability. And that is why what happens in Nigeria, we tell our patients that, especially for the physiotherapy profession, we ask our patients to do a particular task. We tell them that they should execute a task. But because we do not know that they exhibit kinesiophobia, or they have this fear of movement, we just keep telling them, you can do it, you can do it. But there's a gulf of kinesiophobia limiting the patient from doing what we want them to do. So unless we address this fear of movement, we will not have effective treatment outcomes. Based on all of the research findings that I've just talked about, the ones from developed nations, I discovered that, that when an individual has an injury, definitely the patient will have a pain experience. And if such a patient has pain catastrophizing, there will be fear of movement. That individual will avoid executing any kind of task. The individual will not want to do anything, will not want to move the joint, will not want to perform any form of activity. And what do we have resulting from that? Disuse, disability, and depression. And we go into a kind of a cycle of non-effective treatment outcomes if we manage this kind of a patient. On the other hand, if we have a patient that does not have catastrophobia, that does not have pain catastrophizing, this individual is able to confront whatever challenge he or she has, and gradually the individual gets to the path of recovery. All of these falls under the domain of the biopsychosocial model of care. I said that there should be a paradigm shift from the biomedical to the biopsychosocial model of care. So let me talk about Mr. Ladigi again. On this particular day, Mr. Ladigi, after I had finished treating him, after about 5 treatment sessions, I treated him for close to 25 treatment sessions, but I always evaluate his symptoms, at the end of about 5 to 7 treatment sessions. On this particular day, after we had received close to 25 treatment sessions, Mr. Ladigi now said he wanted to discuss something with me. And I actually felt that maybe he wanted to express gratitude for the way I had managed his pain, managed his limitation, because there was a decrease in the pain intensity level. There was an improvement in the range of motion. So that was what I thought. And I was so happy that, let me listen to what he has to say. But I was actually shocked to my marrow. But I thank God that was what jolted me and brought me into this research of the health outcomes assessment, research of the patient-centered outcomes that I'm presenting to you today. So Mr. Ladigi told me that as a polygamist, he was a polygamist, that as a polygamist, he was not able to perform his duties as a man, that is the sexual activities to the 2 wives. And that was a bit of, it wasn't even just a bit of concern, it was a huge concern to me. He was so much bothered about the fact that he was not able to meet the sexual needs of his wives. He was already anxious, he lost confidence in himself as a man. And on that particular day, I thank God that I didn't know about active listening skills, but I listened to him very well. I told him that I was a physiotherapist. I didn't know how I was going to manage sexual functioning. But the fact that I listened to his story and thereafter I decided to include sexual functioning in the goals that I set for him. I included it in the goals for his management. And I was assessing him periodically, even though I didn't do anything. I didn't do anything extra in managing sexual functioning. But the fact that each time he comes around for his physiotherapy visit, I would ask him, can you rate your sexual activities with your wife on a scale of 0 to 10? And that was all I did. And I didn't know what happened. After 5 sessions thereafter, Mr. Ladigi reported to the clinic on a particular day and said he was happy and he was fine, that he didn't need, there was no need for physiotherapy, and that he wanted to be discharged. And that was the story of Mr. Ladigi. And eventually the story ended on a very good note. So, with this impetus to the era of accountability and outcome assessment, the demands of the third-party payers of health. I know what obtains in Canada. We have health insurance companies taking a huge proportion of the health financing of the healthcare funding or financing of patients. But then, because of these demands, no healthcare provider can just afford to treat patient anyhow without considering the beliefs and values of the patient. Changes in health policies have demanded that we should move from physician-centeredness to patient-centeredness. And if we look at the International Classification of Functioning, Disabilities and Health Constructs of Consequences of Diseases, that I talked about earlier in my presentation, it is very, very imperative that everybody should get on board and move to the era of accountability and outcomes assessment. Now, the paradigm shift in Nigeria, those of us, those healthcare providers in Nigeria cannot afford to just fold their hands. There is a need to shift from that paradigm of biomedical model of care to the biopsychosocial model of care. And a report that I did with some of my colleagues again, we reported that patients in Nigeria, the Nigerian environment, they are not just concerned about being restored to their pre-illness state of health, but they are also concerned about receiving psychosocial support. That means this patient also learn to have the biopsychosocial model of care. In Nigeria, we really do not have the third-party players of health funding healthcare. In fact, according to Alawode and Adewale, in 2021, only 5% of Nigerians have health insurance. 70% of Nigerians, they pay out of the pockets for their healthcare. And the rest of the funding is from the government and from the donor funding, the world financing. That is a huge concern. But I know that we will get there when majority of individuals will have insurance, and they would have to provide evidence of interventions that are focused on patient-centered outcomes. And the era of accountability and outcome assessment are the imperatives for the paradigm shift. We just have to shift. We have to shift from the biomedical model of care to the biopsychosocial model of care. But then there is a cultural conflict. Even when the healthcare providers are in the know of this biopsychosocial model of care, there are huge demands of the healthcare provider. One of these demands is the healthcare provider-patient ratio, where you have so many patients to be attended to by a healthcare provider. When you have so many patients that you want to attend to, the natural thing is for one not to have time to incorporate the patient in the shared decision making. But that is the cultural conflict one of the cultural conflicts that we have in Nigeria. Again, in Nigeria, I don't know how it just came about, but the healthcare providers are usually regarded as the major decision maker. There is this perceived power distance between patient and healthcare providers, such that when a patient gets into a treatment cubicle and is being clapped, the history is being taken, he or she does not see the need to raise concerns or to ask questions or to be communicated to in a meaningful manner. So the patient does not share in the decision making because there is that acceptability, cultural acceptability that the healthcare provider cannot be played with. Whatever the healthcare provider gives to the patient is the best thing. And that was what happened in the case of my management with Mr. Lagidi. We didn't even think that they should ask questions because, so to speak, the healthcare provider should be seen as law, as the person that is the only major stakeholder in decision making. Again, there are stereotypes in Nigeria. Stereotypes in such a way that the elderly patient actually feels that, well, I don't have to say anything. This person knows everything. He knows all. So even if he tells me to do anything, I should just imbibe whatever suggestions or decisions that he or she makes. So these stereotypes are some of the things that will not allow for a smooth transition from the biomedical model of care to the biopsychosocial model of care. Then there's this assumption that when a patient carries out some tests, the results are in the exclusive domain of the healthcare providers. You do not have to ask for the explanation of whatever the test results are. I've also been a victim. There was a time my dad had suffered a stroke, and my dad had to carry out so many tests, and the results of the tests were not given to him, were not even given to me, even as a healthcare professional. The test results were kept in the exclusive domain of the healthcare provider. And I think that is just not good enough. That kind of cultural conflict where the patient cannot talk, the healthcare provider sees himself as the major decision maker, the healthcare provider thinks that he or she has to attend to all the patients, regardless of whether the patients contributes to the decision making. So how then can we solve this cultural conflict? There are so many possibilities to explore. One of the major possibilities to explore is education. Education in terms of getting the patients to know his or her rights, that you are supposed to be a decision maker in your own healthcare. You are supposed to be a partner in your own healthcare. The healthcare provider too should have information. The healthcare provider should also have the information about how to communicate. He or she should be able to communicate to the patient as it relates to the diagnosis. The patient should be given an explanation, clarifications should be sought where necessary by the patient. The patient should ask questions about the treatment plan. And of course, talking about the care of the patient, it should be collaborative. It should be coordinated. Patients should be engaged in managing their care. They should be treated with respect and compassion. The kind of care that should be given to them should be compassionate care. And when we have to follow them all, patient-reported outcomes should be used, not outcomes that are not meaningful to the patient. Patient-reported outcomes measures should be used in evaluating the end result of our interventions with the patient. And they must also be given opportunity to provide feedback. In all of these, I just want to say that I am not a judge. I'm not judging healthcare providers in Nigeria. I'm not judging anybody. I'm not judging physiotherapists. I'm not judging physicians. I'm not judging nurses. I'm not judging pharmacists. I'm just a concerned individual. I'm just concerned. I just want what is best for the patient. I'm passionate about change as it relates to patient care, especially in the elderly population that are quite vulnerable in Nigeria. So I also believe that cultural paradigms are not easy to change. When you have a paradigm that is based on culture, they are not easy to change. They are like the journey of 1,000 miles. So my talk basically essentially is about how to initiate the few steps. Even in Canada, if we have such cultural paradigms or we have paradigm of the biomedical model of care, there should be an impetus to change to the biopsychosocial model of care. When we initiate the few steps, then these cultural paradigms will be broken and there will be a shift to global standards of care. I am actually looking forward. I'm looking forward to a world, whether in developed nations, in developing nations, in least developed nations, in underdeveloped nations, wherever, a world where the gospel of patient-centered care in an enabling environment for the healthcare providers, that gospel, a gospel that is preached in that manner. I am looking forward to a world where patients, regardless of their location, regardless of their status, regardless of their culture, can be treated with a focus on what matters most to them. Those are my thoughts. Those are what that have given me this interest to make this presentation today. I want to thank you all for listening. But before I end this talk, still thinking again that, well, this is supposed to be a lunch hour. We're supposed to all have our brown bag handy. I'm thinking that would it be possible if I have to have an opportunity to visit the University of Lethbridge, okay, physically, would it be possible for us to have a cultural shift of meals for the brown bag? I'm looking forward to a time when, okay, what we would have packed in our brown bags will be a bowl of Nigerian jollof rice. I want to thank you very much for listening, and I'll be happy to take some questions. Thank you.
And thank you very much, Dr. Odole. It's a pleasure to see your presentation and lots of space and opportunities. So we do have questions, and as I see in the comments, clearly people are still hungry. Dr. Adesola points out that such a shift in meals would be hot and spicy, and I fully endorse that shift. myself, since I haven't had lunch yet either. It looks delicious. So we do have one question that was put in the Q&A. So I'll just read that out. I've also forwarded it to Dr. Odole just to make sure that she has it in text. And you should feel free to respond to this question in whatever sort of context you wish to use. The question is, in developing countries, and certainly this is true in, I think, all states, healthcare services are offered by multiple agents and actors, as you point out. Even though all providers may follow the same approach, the quality of services can vary significantly or substantially. So can we have your reflections on potential solutions to ensure quality healthcare services by all service providers? And certainly feel free to speak to the context of your experience in Nigeria. So somebody wants the answer to everything.
It's fine. Well, I do agree that we have variability in the delivery of healthcare services in developed countries. One way of circumventing this is for us to have standardized treatment guidelines. If we have standardized treatment guidelines that comes across the different kinds of conditions that we manage, then we will not have the variability in what is being delivered to the patients. So I know that there are a couple of organizations and societies and associations in Nigeria that have developed contextual treatment guidelines, because what we have as a standardized treatment guidelines in other parts of the world may not be applicable in the context of the developing countries. So the development of contextualized and standardized treatment guidelines will help us to address the variability, in the delivery of healthcare by multiple agents. I don't know if that addresses the question.
I think it's a great example, and I'll encourage the person who posed that question to follow up if they have any others. We do have a question from another attendee. This goes back, I think, to some of your earlier content around aging and population change, which is certainly relevant for this institute. And the question is, like weather predictions, the further out one goes in predictions, the less certain or less certainty. Regarding population changes over the next few decades, and specifically regarding aging populations, what might be the impact of global warming on the age pyramid and health? That's another big question.
Yeah, that's a very good question. It's huge. Everybody we cannot run away from the impact of climate changes. Climate changes have come to stay. We should map out strategies to address the effect of the impact of climate changes on the health conditions of our patients. So if I'm to address that question, that what might be the impact of global warming on the age pyramid and health, I just hope that the global warming will not yield a high rate of mortality. When we talk about the elderly populations, we know that there's a rise in the elderly population globally. And if we now look at, without the climatic changes, without the impact of climate on the elderly population, they are at high risk of health challenges. By the time we now put the impact of climate changes, global warming on the already existing potential high risk of the health of the elderly, we are in for a huge and enormous challenge that have to be addressed globally, so that we will not have a high rate of mortality of these vulnerable populations of seniors. Thank you.
Yes, a great question. I have a question for you as well. And my previous job was to run a rural research center. And it relates to questions of not just urban versus rural, but culture and gender. So we know, for example, that at least here in Canada, rural men tend to defer care right? And they tend to not communicate about care. They tend to not seek treatment. They certainly don't seek out sort of perimedical treatment, so physiotherapy, massage therapy, etc. So I think your story is really relevant because you point to the dynamics of that person's life as being very important. But how do we incorporate these other dynamics that include place as well as culture and the role of social relationships in terms of care? Like, how do we facilitate advocacy and cultural change within patients as well? So the systems may change, but patients may also need, and not parents, families may need to change. How can we facilitate that?
Okay, thank you. Talking about culture and health-seeking behavior, there is this dominance. There is a male dominance in terms of culture in Nigeria, where the female folks would not seek for health services without the permission of their husband. Like if I can refer you to the case of Mr. Lagidi, for instance. Mr. Lagidi, a polygamist that had 2 wives. In the Nigerian context, really, those 2 wives cannot decide on their own, so to speak, to seek for health services. That is one thing, because of the dominance of the masculinity or the dominance of the male folks in that particular perspective. Then talking about social relationships, one of the things that can help us to address the issue of social relationships and cultural change is for every person to be empowered. It does not matter, being a female, being a male does not disturb anyone from seeking healthcare or health services. Everybody should be empowered. And one of the things that I am very, very passionate about is that every life matters, every individual, whether you're a male or a female, you must know that you should be able to seek for healthcare services without, if you are sick, just look for a clinic or a hospital to go to. You have to seek the services of healthcare professionals. Another thing again is that education, even for the male folks, when we talk about pain threshold, the masculinity again, sometimes when a man has pain, the pain experience is sort of masked by the man, because the man does not want the woman to know that, an expression of pain is seen as a sign of weakness. So the male folks would rather not want to express the pain until whatever disorder or disease or condition that they have, until the severity gets very, very bad. And they now report to the clinic when attention that should have been given at the early stage of the disease was not given, and the patient now has maybe a kind of condition that cannot be fully attended to by the healthcare provider.
Great, thank you. We do have another question coming from the audience, and this is related to funding and government, so legislation. So the question is in 2 parts. How does the poor funding of healthcare in Nigeria affect this paradigm shift? And can this approach or shift be legislated or passed into law across the 3 tiers of government in Nigeria?
The poor funding of healthcare in Nigeria, I just told you that most of the time it is out of the pocket. So what it means is that the less privileged, those individuals that do not have financial muscle, so to speak, to seek healthcare in the hospitals, sought for unorthodox ways of management. They go to see traditional healers, traditional bone setters and all the stuff to manage their condition. So that would adversely affect their management. But relating that to the paradigm shifts, those of us that are healthcare providers, it is only when you come to the clinic or you seek medical attention, whether at the primary level or the secondary level of care or the tertiary level of care, that you will have contact with the healthcare provider. If a patient does not attend the clinic, he or she will not be managed by the healthcare provider. So how would and for you to come to the clinic, that means you have the money, you have what it takes to come to the clinic. But we also have government tertiary hospitals that are being subsidized by the government. So we have a lot of individuals attending such clinics where the government subsidizes the financial burden of care on the patient. So basically, these would not adversely affect the paradigm shift. The paradigm shift actually borders on the healthcare provider majorly in Nigeria and partially to the patient, because the patient has to know that he is a partner in the decision-making process. The healthcare provider has to give the enabling environment to the patient to be able to listen to the patient, to be able to incorporate the patient's values, beliefs, and opinions in the care. So if a patient attends the clinic, whether private clinic or whether the government subsidized clinic, it will not affect the paradigm shift. If the patient is empowered and the healthcare provider knows that the patient should be allowed to be a partner in the decision making, there wouldn't be any problem. The only problem is for those people that do not seek medical intervention in the clinics, whether private or government institutions. Those are the ones that these paradigm shifts will be affected because they stay in the confines of their homes, they stay in their communities, and they manage themselves in an unorthodox kind of way.
Okay, great. Thank you very much. Are there any more questions? People want to type, we'll just take a minute here to give people a chance to reflect on the content. You've provided a lot of content today and certainly a lot to think about and consider. Certainly in my experience here in Canada, while we've seen different models of patient-centered care put forward in different contexts, e.g. in palliative care or in continuing care more broadly, it is very clearly a cultural change question. It's not just organization, it's actually how people, both working within healthcare and in paramedical care, as well as patients and families, think about the role of care and the role and values and rights, if you will, of patients. And particularly as patients get older, in my experience, it becomes essential that family members and caregivers can, in fact, advocate for and know what the values and the challenges are for patients who may be struggling with issues of dementia, may have issues of mobility, but also sort of varying cognitive gaps, even in terms of aphasia, so their ability to express their positions and opinions. So maybe as a last question, what does the perfect world look like for care providers?
That's just a moment. I just saw a question that I didn't quite answer. That can this approach or shifts be legislated or passed into law across the 3 tiers of government in Nigeria? It can, but we have to start. I said it's like the journey of 1,000 miles. You already have a cultural paradigm. We'll just start taking these initial few steps and begin to make advocacy, begin to advocate. Okay, by the time we have strong advocacy groups talking about patient-centeredness, then we can now have all of this approach or these shifts being legislated and passed into law. That is the kind of world that I'm expecting, a world where a patient is bold enough to ask that he be considered as a partner in decision making.
That's great. Thank you for answering all of the questions and for bearing with us as we fixed the technical issues earlier on today. I'm very happy to see that we were actually able to complete this webinar successfully with video as well as shared screen and sound. So I'd like to, on behalf of the Prentice Institute for Global Population Economy, thank Dr. Odole for her time and her presentation today and for situating not only a comparative and international perspective but also thoughts that are clearly very relevant to what is happening here in Canada and many parts of the world. Thanks to all of the attendees who joined us today and for their engagement and questions. I'll echo the comment that was just made to the panelists, which is this was very educative, which is what we really, of course, strive to be. And of course, I encourage people to follow up with Dr. Odole if they have additional questions. And we'll see perhaps in some future when travel is a little bit easier, if Dr. Odole may in fact be able to join us in Lethbridge, and we will in fact put away our sandwiches and eat a more diverse lunch at our brown bag. So thank you all for coming. Thank you again, Dr. Odole, for making this presentation. It's a pleasure to see you all here today. And with that, I think we'll conclude this brown bag presentation because it's probably getting quite late in Nigeria right now. We've been at it for a little hour, so it's after 9 o'clock. So again, please join me in a virtual round of applause and thanks to Dr. Odole. And I appreciate everybody for taking the time to join us today. So thank you all again very much. I'll turn on my video to say thank you for coming. And we will speak to you and talk to you all very soon. And just a reminder, there will be another presentation on March 19th. Take care, everybody. Thank you. Bye-bye.
Thank you.